Dear colleagues, dear friends, thank you for being with us today at the UROONCO platform on the EAU TV. I'm very pleased to have my guest today the leaders of the ResECT study, Professor Kasivisvanathan and Dr. Gallagher. I'm very happy to have you here. Thank you very much for coming. Please, can you tell me and tell to our audience what is the rationale behind the ResECT study?
Thank you, Ben. So, we're interested in non-muscle invasive bladder cancer because we know the way you do your surgery, the TURBT, and the perioperative practice around that can make a big difference to your outcomes with respect to recurrence and progression. And we know from work from Pradere in the Scottish study that when you look at your outcomes as a group and see how good you are in achieving quality indicators, it can actually improve your performance as a group. So we wanted to investigate whether or not we could improve the achievement of quality indicators when we run a study, which is an observational study, but with an embedded randomized trial of education to see whether people improve.
Very interesting. I think this makes a lot of sense as in the EAU guidelines since this year, 2024, in the updates, we have implemented these quality indicators. Can you tell us maybe a bit more about how went the study regarding the methodology, the follow-up of these things, and how many centers were included?
Sure. So it was quite a large global study. It was a burst urology study. So we had 200 centers who were randomized, and we had just under 17,000 patients included in our primary outcome analysis. And we ran the study by recruiting centers. We asked them to provide us the results of their retrospective data, so we had a baseline for how they performed before they were being investigated. We then randomized them to either the enhanced feedback arm, where they had a peer review comparison website where they could see how well they did with respect to achieving the quality indicators compared to their colleagues. And they would get education to improve in that arm. For example, the detrusor muscle in the specimen, if they were performing poorly in that quality indicator, they could have a video to see how that might be achieved. There were two documentation outcomes, which were looking at documentation of completeness of resection and the tumor features, for example, size, location. And if they didn't perform well in those, for example, they would have pro formas to be able to institute that in their own sites. And the last quality indicator was single installation mitomycin C.
And the primary outcomes was the performance of the use of these quality indicators?
Correct. Achievement of those four co-primary outcomes, which were quality indicators, and secondary outcomes were recurrence rate at early stage.
Fantastic. And so, Dr. Gallagher, you presented today the results of the study. So let us know what did you found?
Yeah, so really interesting. Important to realize that the primary analysis is comparing the effect of that intervention. So having a peer comparison feedback and checking yourself against your colleagues against just taking part in the study. So the control arm was taking part, collecting their data. They knew they were being watched, but they didn't get that feedback intervention. So with that primary analysis, then we found that there was a significant effect of the intervention for the documentation outcomes. So the intervention caused people to document all of the tumor features better and to document whether or not they'd done a complete resection, and that's important. It didn't have a significant impact on single installation rates. The intervention didn't have an impact, but there was a real trend for single installation rates to improve overall. So there was more single installation during the study than there was before. And this means this dilutes the effect of the intervention because there's an improvement in the control arm just because they're getting watched. The detrusor muscle outcome, there was no effect of the intervention, and actually at baseline, it was really good. So the median detrusor muscle resection rate was about 80% at baseline.
That's good.
So probably not much room for improvement there, and that outcome probably had a ceiling effect. The really interesting outcome is the first check recurrence rate. So did this have an impact on the recurrence rate? The answer is that the intervention didn't, over and above the effect of just taking part in this study. But just taking part in this study resulted in a reduction of recurrence rate from about 25% at first check down to 19% at first check, which is actually quite a big difference between the baseline and in-study recurrence rate. something's happening. All the surgeons are doing better because they're taking part in a study. They know they're being watched.
Yeah, and they have been educated somehow.
Yeah.
I think this is for us as urologists and from the EU guidelines part. I mean, we are always thinking on how can we be sure that the guidelines are implemented, followed, and used on the right way. And I think this kind of is tremendously important for us, because you can see that if we educate more, if we take more time to give the surgeons, to give the institutions the quality indicators, all the marks, the landmarks for getting better, you prove that you have a better results, right?
Yeah. So the question is, how do we take that effect beyond the study, so that you don't just get that benefit of being watched in a study, but you get that into real life? Is the question, really.
That's the question.
And I think we have the answer. So to me, this is quite a clear indication that taking part in national audits or international audits of your practice will improve your outcomes with respect to recurrence rate. So I would be supporting, on the basis of this study, national audits of non-muscle invasive bladder cancer and achievement of TURBT indicators, as they do in Scotland, but in other centres now.
Yeah, and we are really looking forward for that, and that they will follow these new quality indicators. Will we have more results regarding the ResECT study in terms of oncological outcomes? Have you planned some post-hoc analysis or things about that?
So the primary analysis will be the comparison between the randomized arm and the control arm.
Okay.
Secondary analysis will look at the recurrence rate, for example, in the control arm, showing the Hawthorne effect just of being involved in the study. We will look at predictors, in terms of predictors of recurrence rate on an individual patient level, adjusting for some of these factors. Now the centres have completed the study. Technically, they have access to their data, even if they're in the control arm. So there will be a bit of contamination, but it is possible to ask centres to report their longer-term recurrence and progression rates if we think that's a reasonable thing to do.
Great. Last question. So this study is, again, driven by the burst, and I really have to congratulate all the job you're doing with all these fantastic multicentric studies that you're driving right now. I think it's a very inspirational way of thinking, and the way you develop it, it's really amazing. How many countries do you have represented in the BIRST study, in this one, in the ResECT one?
Wow. Kevin?
I think it's 48 countries.
48 countries, wow.
Yeah.
So Europe, but also outside Europe, US and so on?
Yeah, North America, South America, every continent, Africa,
worldwide.
Australia, yeah.
That's fantastic. Yeah.
One of our key principles is we want our studies to be accessible to your average urologist in any country in the world. And I think that's why people want to take part, because it's easily accessible.
Yeah. Guys, thank you very much for your time. It was really a pleasure for us to have you, and congratulations again for what you're doing.
Thank you.
Thank you very much.
Thank you.